hopefully that's gonna work.
Hi,
Ah, yay!
hi, Ruben.
Oh my gosh, welcome. I'm so embarrassed. It was
Wow, technology, this happened. So we are here. We made
things do happen, that is for sure. Well, I am glad we got it to work. Welcome.
it.
So, welcome
I
everyone, and thank you all for your patience. I am Cindy Rubin. I am a general pediatrician and breastfeeding medicine specialist outside Chicago. And today I have a very special guest, Dr. Sheila Perez-Colon, who is an endocrinologist in Puerto Rico
yes,
currently, right?
here.
And she has graciously joined us to talk to us a little bit about hormone therapy and its use in treatment for short stature in kids who have normal hormone levels. So first, tell us a little bit about yourself and how you got to where you are. And I believe you are opening a new venture soon as well, which I would love to hear about.
Yeah. So I'm Dr. Sheila Perez-Colon. I'm a pediatric endocrinologist. I was born and grew here in Puerto Rico. And after 22 years being out of the island in the US, in different cities, New York, LA, and Miami, I'm coming back. I'm coming back home. I'm bringing here a model which is called the direct specialty care, in which I try to give, and I will be giving personalized care to my patients direct. I will not be dealing with, third parties. I will be just the patient, the family, and myself. I think that patients deserve more time, deserve more quality care, and that's what I'm looking for. So I'm opening my practice very soon. The first week of September, I will be seeing patients.
Yay, that is soon.
Yes, I'm.
Yeah, congratulations. I can tell you from, opening my practice for very similar reasons, just to have more time and be able to give patients the time and care that they deserve. It feels really good. So I think you're going to love it and your patients will love it.
Yes, I'm looking forward to it.
And it's great also having this community of other independent physicians who can support each other and help each other out and learn from each other like we are
Yeah,
today.
yeah, exactly. We met that way, and I love it. Yeah, we can share all our, ideas. How can we improve? What can we learn? So I love it. I love being in this community.
Absolutely. Well, especially since we're running a little bit late now, let's move towards our topic. So actually, this is an interesting topic that I believe I heard about first when a patient came to me and asked me about it. And I was like, what? I've never heard of this before. And I find it fascinating. I myself am 4'11", never quite hit 5 feet. And so I have just genetic short stature, constitutional short stature. My parents were both short as well. And I have lived with it fine, though, it has been, I have had some struggles socially, probably more in my mind than anybody else's, through my life. I think this can often be more of a problem socially with boys as well. So I would love to hear just how this kind of came about and how you've seen people come to you about this in practice.
So yes, definitely. We see a lot as a pediatric endocrinologist. I see a lot of patients that present for evaluation for short stature, and then there's different cause of or etiology, right? So it could be
Right.
definitely has growth hormone deficiency, so that hormone that makes us grow is not there, or is partially produced, or is not produced at all. So those are like kind of clear because we know we do the workup, we find out that has growth hormone deficiency, and we start them on growth hormone, and they tend to respond very well. But then there's other types of, or etiologies for short stature. For example, like you mentioned, like familial short stature, right? Because it's due to genetic. Like mom and dad are not that tall, so we can expect, right, the daughter or son to be tall. because that's not how it works. Everything is through genes. We do the workup though, we try to, first, how do we start the evaluation for short stature, right? So we can explain it and then we reach to the treatment.
Yep.
Patients come to the clinic, right? Or parents, they are concerned about, my child is short. When I compare them to
Oh my gosh, I suddenly can't hear you anymore. I don't know if other people, another technical. Oh, there we go. Okay.
No, so when patients are having short stature, they need evaluation, and what we go first is to evaluate the growth velocity, right? So every time the patients come to the clinic and first to the pediatrician, we do the weight and height, and then with that height, then we plot it on the growth chart, right? And then for months, depending on how often they come, we measure them again, and we calculate what is called or known as growth velocity. It's like how that child is growing through time.
And how much should a child be growing over time?
Yeah, so it depends. Definitely, during the first year, the first 2-3 years, we grow faster. Kids grow very fast, so the growth velocity is increased. But then up to like 4-5 years of age, it should be calming down, going down that growth velocity. But typically on a child, it should be approximately 5 to 6 centimeters per year.
Mm-hmm.
And then we go through puberty, that should be higher, 8, 9, 10 centimeters per year. But something that is important to know, when babies are born during 12 months, 16 months, 24 months, that growth velocity will be increased. It's very similar to the growth velocity in puberty, but that's normal. So if that child, for example, if we have an 8-year-old boy that is coming and we measure and the growth velocity, it's like 3 centimeters per year, we say, that's not appropriate. He should be growing more. Do he deserve, do we need to do the workup? And along with the physical, findings and about the clinical, then we go ahead and say, okay, they need it. We do blood work and we do an x-ray to see. Yeah.
Just for our viewers who are not familiar with it, how does an x-ray help?
Exactly. So the X-ray is called a bone age, right? It's just bone age is just the name. It's the age of the bone. That's exactly what we're looking at, and it's an X-ray of the left hand. Okay, and then we just take the X-ray and then we read it. Radiologists will read the X-ray, but we pediatric endocrinologists read it as well. For example, I read all my X-ray and I could agree with the radiologist, or sometimes I may disagree, and I will give my own reading. Normally our chronological age, meaning our age, the 8-year-old boy, it's the age year is the chronological age. The bone age should be similar. If that bone age is red, when we see it, the ossification center, it's like the epiphysis, there's some findings that we look at, shows that he's like a 6-year-old, that bone age is of a 6-year-old. We say, there's something here that we may be missing. He's 8-year-old chronologically, but the bone age is read as a 6-year-old. There's a difference of 2 years there. What could it be? And then we go into, okay, could this be, for example, growth hormone deficiency itself? Could this be like related to thyroid? Could this be related to delay on puberty, constitutional delay of growth and puberty? So that helps a lot. On the other side, also when we have an advanced bone age, right, meaning like he's an 8-year-old, but the bone age is about 11, 12 years old, we also say, something is not right here. Why is the bone age so advanced compared to the chronological age? And we also try to rule out, endocrine conditions and non-endocrine conditions that could cause it.
Great. Thank you for explaining that. And so let's say you do the workup, you see that something's off, you do the workup, and everything comes back normal in terms of your lab work. Maybe the bone age is a little off though, potentially, or the bone age is normal. How do you counsel parents then?
So I see the bone age, but again, I see everything, the clinical and the finding, because I calculate, I say, okay, I get the height of the parent, mother's height. Ideally, I like to measure them both myself in the clinic, so I get an accurate measurement. However, most of the time, both parents can come, so I will measure one parent and I will get the verbal report of the other. But with that, we use a formula to calculate. And this is called the mid-parental height or the target height, meaning that according to this family, this child should be growing around this number, right? Or this
Yep.
percentile. That's called the target height. Versus then we say with the bone age also, it helped me also to predict how tall that patient will be or how short that patient will be. We do a calculation and we say your mid parental height, you're supposed to be around, I will make this up, like 50 percentile, or you will be around 5'5", but then that's for the mid parental height. But when I calculate where you're growing, it's coming like 4'11", for example, like you measure, and I say, that's not. You should be close to your genes. You should be close to your family. What is happening here? So meaning overall is like not everything is growth hormone deficiency. There's sometimes other conditions that we can treat with growth hormone. For example, there's babies that are born small for gestational age, that they don't catch up, and they not necessarily have growth hormone deficiency, but we treat with growth hormone. Also, there's something called idiopathic short stature, right? Everything in medicine that we don't know yet what is causing it, we make sure it's not many conditions, but then we call it idiopathic. So idiopathic short stature, it's one of the indications for growth hormone. Also, like kidney disease, kidney disease, along with many syndromes like Turner, Noonan, many syndrome, Prader-Willi. So it gives us a lot of idea the bone age, and we can treat not necessarily for growth hormone deficiency. There's some approved to treat that are other causes. However, there's other situations. Sometimes, we want to be taller. Maybe the familial, right, or potential, the genetic potential comes around 5'9" or even 6, and we want our child or the child to be even taller. On that conditions, I will say no. I do all the workup, and if everything is okay, then I consult the parents and say, right now he's growing along where he should be. Sometimes in this situation, giving growth hormone may do more harm than help, and that's something that we need to have in mind. Growth hormone is a therapy. It's a medication that is very helpful, that we use frequently. I use it very frequently, but it's in situations that are indicated, right? Because we need to monitor for side effect, be monitoring the level. So it's not just to start like a vitamin and that's it.
Gotcha. So what are some of those risks?
That of the side effect or risk? Well, the most common usually is like when we start growth hormone, they may complain of some headache. It could like increase intracranial pressure. Okay, and typically what we do is like if the patient complain of that, is severe headache, we will see them. We may stop the medication. We may need to do some imaging in some conditions or some situations, but then we can restart it, and we restart usually at a lower dose. Also, side effect could be if the patient has already existing scoliosis, right, of the spine. We can start the growth hormone therapy, but we need to be monitoring them because we know that on those patients, it could make it work, the scoliosis. So that is one of the side effects. Also, it could affect at some point, and usually it's at the beginning of the treatment, your glucose metabolism, some kind of insulin resistance, or it may even affect your thyroid function test. Some patients we just monitor and they are fine. Rarely some patients may need treatment, and if they need treatment, usually it's temporarily. Dr. Rubin's, many patients are concerned about, for example, they hear growth hormone and they think about the concern about cancer, having risk for cancer, having risk for stroke. And I know it's something that has been a debate through the years, but usually if a patient, for example, has a primary tumor, for example, or has been receiving some radiation, some therapy for that, then we need to wait at least for a year before we decide that those patients are candidate for growth hormone therapy. And those patients who has a primary tumor or malignancy, yes, they have increased risk for developing in the future. Doesn't mean that they will have it, but they could. And also, if you have conditions like Down syndrome, some conditions of your blood, like Fanconi, many other conditions that are already predisposed to cancer or malignancy, giving growth hormone therapy put them at risk. But on patients who are healthy and they don't have risk for that, usually there's no risk for developing cancer, or it's the same as the normal population.
Gotcha. Yeah, that's a lot for families to really think about, especially when this seems to come to light during an age when kids are already kind of struggling with figuring out who they are and how they fit in. And so I do think that it can really affect, just the short stature end of things can really affect kids' mental health. And I personally, as a pediatrician, have had patients in this situation, and we use mental health therapy to help them kind of through that, since the risks of that are really slim to none. And the risks of therapy, of actually using the hormones, are much higher. But every family has a different, risk threshold and tolerance. So I can see how some people, depending on how, a person's goals and a person's personality, can really affect their decisions. And I think it's fascinating that people are using hormones for this purpose. Is growth hormone the only option in these situations?
Well, for growth overall, it's the main, it's the one that we've used the most, is growth hormone therapy. There's other medications or condition or injections that we could use. For example, sometimes we use like combinations of aromatase inhibitors, or we use like the analog or the gonadotropin releasing hormone on certain conditions. But actually, there are not a lot of studies. Sometimes we do it out of it's not indicated or approved by FDA, and we just do it in clinic to see how they are doing. But mainly, it's growth hormone therapy. It's growth hormone therapy that make them grow. Saying that, like I mentioned before, I'm very careful to whom I prescribe growth hormone therapy. I don't prescribe it to everyone. It really needs to be indicated. But I do believe of the basics, which are, for example, what make you grow. Remember, like growth hormone is released from the brain and it's pulsatile, right? And it's important, it's released during sleep. So I always go in detail with that family, how the amount of time that the patient is sleeping. I recommend they should be, depending on the age, they should be sleeping around, just to say, 10 to 11 hours, okay? We need to reach that goal. Otherwise, if we compromise and they sleep very, very few hours and they don't sleep well, their health could be compromised. Other is like exercise. We know that exercise is very important, and it actually induces the release of growth hormone. In the past, one of the ways that we could see if the growth hormone is released or if there is growth hormone deficiency, it was like to do an exercise test, like to put the child or the adolescent like to run to see if there was growth hormone production. Nowadays, we don't use that. We give other medication to see if the growth hormone is produced or not. But just to know, like, exercise is very important. I go about that. I talk a lot about diet, healthy eating, and I talk about the importance of sleep. So we always have something to educate parents, right? It could be basic. It may not be pharmacologically, or we may need to go into pharmacological medications.
Wow, that's fascinating. I think we think of those things with babies a lot, but not with older kids. Yeah, that's fascinating. I'm going to have to get my son to sleep more.
Yes, I do a journal and everything. Yes, it's very important, and not just for growth, for everything. To be doing is for health, for development, everything, for mental health.
Right. Absolutely. And how effective is the treatment? Like, let's say somebody, goes through all of the risks and their hormone levels are normal, but they are, have idiopathic short stature and want to do the growth hormone. How much effect is it likely to have? And is there a time when it's really crucial to do this?
Yes. So patients who will respond the best are those who have growth hormone deficiency. Let's think about it, right? You don't have the body doesn't have or is lacking the hormone. As soon as we give it, it light up, like they respond very well. And actually, on those patients, we can give, and we give actually lower doses because we know they will respond. But those patients like idiopathic short stature and the other we mentioned that they do not have growth hormone deficiency, they don't grow as much as the growth hormone deficiency patient. Also, once we start the growth hormone therapy, we're going to be monitoring, right? Remember I spoke about the growth velocity just when they come for evaluation. So for treatment, it's the same. They will be coming to the clinic every 4 to 6 months, and we will be monitoring the growth velocity. If we see that that growth velocity over that year that we start the growth hormone is very later, like kind of growth failure, like 2 centimeters or less, for example, then we say, I recommend then let's stop the growth hormone because it's not helping you. So that's when, what health risk versus benefit comes in. So on those one, we say no. And then other one is like we check the bonnage, right? We want to make sure those ossification centers, they are not closed, the epiphyses are not closed. Because I always tell my patients, if you come, sometimes they present and they are 17, 18 years old, or say, too late. We do an x-ray to confirm, and the bonnage are already like a 17-year-old or an 18 years old. By then, most of the bones are already closed, 99%. They still could grow here and there, but most of the bones are closed. And if I give growth hormone to those patients thinking they will grow, they could develop acromegaly, right? So that means instead of going to the bones to grow, other parts of the body will grow. It could grow, like, for example, like the nose, like the ears, and it's true. We have seen it, right? So it's important for them to know that there's a time for it, that not every patient is a candidate for growth hormone, but we do have the option. So my recommendation is if the child is being short or is concerned about being short, it's very important to take to the pediatrician to be monitored, to be calculating the growth velocity. The pediatrician then we reassess if there's a need to refer to the endocrinologist, if there's any concern by the pediatrician, the growth velocity or findings, and then we can then do everything. If we found any deficiency, we may treat. If we don't find deficiency, then we say, it's good. There's nothing wrong with you. There's no deficiency. We predict the height. We say this is more or less where you're going to end up. And then we say, could you benefit of the growth hormone or not? But most of the time, really, it's not indicated. It may help, but it's not 100% that it will help. I tell my patients, we can start it. I'm okay with this finding and we can start it, but I don't promise that you will grow like 10 centimeter, 8 centimeter. You will gain like maybe 2, 3, depending on when we started, where you are in puberty. Yeah, it's a constellation of things, we need to have in mind before we give the treatment, especially when there's no growth hormone deficiency.
Right, right. Now, is this something that you would use in the situation of constitutional growth delay, when everything points to the fact that this child will reach
Height?
acceptable height, but is just taking longer to start puberty and have that growth spurt? What do you do in those sorts of situations?
So I don't, if I think if they have constitutional growth, right, or delayed puberty, it's because they are just like, they are entering puberty late. We call them the late bloomer, meaning like we do the workup, everything is fine, but we take the history from the family. And most of the time, the father will say, I entered puberty late, or the mom will say, oh, yeah, that just maybe a 15, which is late. So we already know, I'm already having in mind, there's a strong history of delay or late bloomers. Likely this is a late bloomer. Plus, blood work is normal. We'll do all the workup. It's the same for every patient with short stature for blood work. We make sure they don't have, for example, anemia, chronic anemia, that they don't have any kidney disease, that they don't have any inflammatory bowel disease. We make sure they don't have celiac, actually, because in celiac, sometimes patients think, they don't have abdominal pain, they don't have bloating, but in pediatrics, they may just present with short the poor growth velocity, not growing well.
Yeah.
And then we make sure the thyroid function test is okay and the growth hormone level is okay. And we don't measure growth hormone. Growth hormone is pulsatile. So we measure what is called the IGF-1, the insulin factor, like growth factor 1, and the IGF-BP3. So once we do all that and it's within normal, and then we do the bonnage, that bonnage may be delayed. And with the finding that patient is not in puberty yet, it is late, the family history of late bloomer, blood work is normal, and the bonnage exactly is delayed, this may fit the constitutional growth delay. And then we say, you know what, I know some patients get get frustrated because they want to grow. But on these patients, I don't offer growth hormone. I calculate the predicted height, which is like with the bone age. You see, you are here right now, and the growth velocity on these patients may be normal, but maybe a little low, also a little low. And I calculate, and then you come back to where he should be, the mid-parental height, and I say, let's just give some time. But I understand, you know, in school they get bullied, they are stressed, they are really short. You know, they will grow, but they are really short. Sometimes we may give like testosterone, like try to enter them into puberty, right? Some hormone try to get them there. But for growth hormone, I usually do it if there's growth hormone deficiency or if the factor is low. If there's a constitutional delay or this is growth hormone deficiency, that's when I may do growth hormone deficiency. But for the other, it's really like just that help them go into puberty if it is needed, or just like we calculated, you will grow. Let's just do exercise, sleep, and all that.
Yeah. Yeah. Well, that's interesting. So testosterone could jumpstart things. Is there an age at which your cutoff would be for when you would use testosterone to jumpstart?
So it depends. You know, we usually use like the 11 years of age to see, but it depends. It case by case, because if they present at other ages and I still think it may help, then I will do it. It's more flexible.
Okay, interesting. And I assume there's a whole list of risks there as well, probably.
Every it's like every medication, right? Like Tylenol, I always say Tylenol, if we look at the back, it risk of liver failure, you know? So as long as we always tell the patient, I'm very clear with my patient and transparent. These are all the side effects, and they may ask me, and they ask me, how often have you seen it or not? I'm very honest. This is what we have. And then we will decide and discuss them. So it's not a surprise for them. Once you tell them this could happen, if they decide that they will start it, it will not be shocking. They will not get nervous because they already know that's a side effect. The problem comes when we don't discuss the side effect or possible side effect with the patients. That's when, you know, things make it wrong.
Right, right. So really important in these situations to first address any concerns about growth with your pediatrician. And then if it's warranted, then find a good endocrinologist to help guide you through it.
Yeah, yeah, yes, definitely. I don't hear you.
Anybody in Puerto Rico needs to find an endocrinologist, or any of us would like to reach out to you for any reason, where can we find you?
Well, my website, it's www.eliteendocrinemd. My practice is, that's the name, Elite Endocrine MD. So you can go there.com and you can find information that soon will be live. Right now I have a waiting list, but I also have Instagram, which is the Elite Endocrine MD, and then _ Dr. Perez. You can write me, anybody can write me there, or even by Facebook. I'm in social media. I'm trying to, you know, little by little, like kind of give some hints at education through social media, because on the era that we are right now, that's a way that we can educate and teach patients. So I'm in social media.
Great,
and then
great.
I know in Chicago, you know, it's not, I will be doing some telemedicine at some point in the US, but right now I'm only in Puerto Rico. But for the persons who are seeing from Puerto Rico, I'm in two hospitals. One is Doctor Center Ciudadela, and the other one is in Sabanera Health in Dorado. I will be in San Juan and Dorado. I'm very excited to be back in Puerto Rico. There's a huge need of pediatric endocrinologists in Puerto Rico, so I'm beyond excited to be here.
That's so wonderful. I'm so excited for you. Well, this has been very enlightening. I really appreciate your coming on and sharing your expertise with us. I think that this will be helpful both to parents who are listening in and also pediatricians who sometimes those endo feedback loops, you know. It takes a special kind of person to go into endocrinology, I think.
You need to hustle, and I love
Right,
it.
right. But I really do find this absolutely fascinating, and I'm sure that we'll have more questions. If people do have questions, we'll watch for them in the comments as this gets posted post-production. And I'm sure that that we will be able to still get answers. And I will post your links and everything also in the comments.
Thank you so much. Thank you so much, Dr. Rubin, for having me. This was a pleasure.
Thank you. And thank you everyone for, I don't know how many people here were putting up with the technical difficulties over on Facebook, but hopefully I'll figure that out one of these days. But I appreciate everybody's patience. And thank you so much for joining me.
Perfect. Thank you everyone for joining. Thank you.
All right. Bye-bye.